Objectives. So let's talk about the spectrum of metabolic disease, that is glucose intolerance, prediabetes, metabolic syndrome, and how that transitions into diabetes. Recognize that cardiovascular risk is elevated in these pre-diabetic and metabolic syndrome, metabolic disease states. And then go through the benefits of lifestyle management for the reduction of cardiovascular risk, and really to understand the benefits of early intensive risk factor modification in type 2 diabetes. And then at the end, what I've put in is if you would like to incorporate into your practice, there are patient-centric handouts that we'll go through with some practical tips of what you can talk to your patients about and give your patients as far as suggestions on how they can modify their risk. So this is the health state of the United States, and diabetes is the lowest map here. And you'll notice that there is overlap between those that have diabetes in the highest prevalence, those that have obesity in the highest prevalence, and that's associated with significant physical inactivity. So really our hypothesis is that, physical activity and both diabetes lead to, or obesity lead to diabetes is typically through this progression, but there are some high-risk individuals that just with physical inactivity can progress to metabolic risk and diabetes, even in the absence of diabetes, and we'll touch base on who those people might be. So, this is a major problem in America. 26 million Americans are diagnosed with diabetes, 10% of Caucasians, up to 20% of African Americans, and the prevalence increases across age groups. And so the projections are that 1 in 3 people by 2050 will have diabetes. We're already at 1 in 3 people are overweight, or excuse me, 1 in 3 people are obese, and 60% of the population is overweight to obese in America. So these are pretty staggering issues that we're facing. Who are the people that have diabetes, and what are the racial differences? Non-Hispanic whites, about 8%, Asian Americans higher. Hispanics have a higher risk as well. And Native Americans have a high risk. The Native American population, Hispanic population, and even the South, Indian and Pacific Islander population can have diabetes really in the presence of being mildly overweight and not obese. There's something just a little bit different about their pathophysiology that pushes them over into diabetes. So those are the groups where the predominant obesity epidemic in Caucasian Americans and African Americans is different in these racial groups, that they'll have diabetes before the BMI is over 30. So what is the economic impact of this? Lots. Billions and billions and billions of dollars. So if you have diabetes, you have your average medical expenditures 2.3 times higher. It causes disability, it causes loss of work, it causes premature mortality. And these are all things from the CDC site. So what's the typical way in which the pathophysiology of cardiometabolic disease starts? Well, it's to an active and overactive adipocyte cells. There are multiple signaling pathways from here that lead to inflammation, injury of the pancreas, concomitant hypertension, changes with all these that lead to dyslipidemia, insulin resistance, and then progression on to type 2 diabetes. This then, with hyperglycemia, leads to increase in all these cofactors, increased risk for thrombosis and atherosclerosis, and then a circle of bad pathophysiology is what continues. What is the impact? Well, we know it affects the kidneys. Nearly 50% of diabetics will progress to some form of renal failure. It affects the eyes with vision loss and retinopathy. It affects the lower extremities with up to 60% of amputations. And really, it causes heart and vascular health with a 2 to 4-fold higher death rate from diabetes. So this is from the looking at, well, what is the 10-year risk for really, let's just use this, of microvascular disease, blindness, end-stage renal disease, amputation, and then net microvascular disease versus heart attacks and strokes. And you can see when you combine them, heart attacks and strokes are 3-fold elevated above that of the microvascular benefits. So people with diabetes die of heart disease. They die of strokes. If they live long enough and they don't die from that, they develop microvascular complications. So why is that a problem if you develop heart disease? So this is what Dr. Gupta in the back specializes in, is taking these kind of pictures. And this is a catheter that's into the left main coronary artery, and there's diffuse disease throughout it. The best interventionalist could work 5 years on that artery and not fix it. There's just too many places to stent. There's too many stenoses, and this is a coronary arterial tree that if it was surgically revascularized, you'd have to ask yourself, what are you gaining by that as well, because there are distal stenosis to where you would put your bypass graft. So it's a diffuse epicardiovascular disease process that is difficult to treat and manage at this stage. So those are kind of sobering things that we're dealing with. So what do we know about diabetes and the glycemic risk on its effects of cardiovascular disease? So really one of the best, kind of most complete studies is from the UK, where a lot of this and data comes from. And you can see as you go from left to right here on the bottom, so increasing hemoglobin A1C as a marker of glycemic control, with increasing hemoglobin A1C here with a percentage increased risk in myocardial infarction, and then a staggering increase in risk of microvascular disease. So both increase with and correlate to your degree of hyperglycemia. And then if you do kind of regression from that and then look at deaths related to diabetes and all-cause mortality, then if we can take people from here through risk factor modification and glycemic control, we can get significant reductions in their hazard ratio, so a 21% decrease in the risk of death related to diabetes and a 14% risk decrease in risk of all-cause mortality by coming down from 10 to 9 to 8 and so on. There's debate on what happens here in death related to diabetes and all-cause mortality, and we'll kind of go into some of the, a little bit of the controversies on aggressive control from here to here, which have been done, I think, in the Accord, the Advance, the VA trial, and things like that. And I'll show you some graphs on that and give you my take. So not only is our elevated hemoglobin A1Cs as a marker of glycemic control risk for all-cause mortality, myocardial infarction, stroke, and death, but in atherosclerosis risk in community studies, or ERIC study, that risk goes down and is continued even below hemoglobin A1C of 7. That risk exists at 6.5, it exists at 6, and all the way down to kind of about 5.2, both for heart attack and for stroke. Suggestive that really at the beginning phases of hyperglycemia, is where risk starts to develop. And then there's a J shape with it, that if you're hypoglycemic or other features that are lowering this, then your risk is elevated. So the risk inflection point is really starting around kind of 5.3 to 5.5 here, both for heart attack and stroke. And it was really this study that the American Diabetes Association then said, well, we really need to define pre-diabetes in a much easier way. And so that's where really the cutoff of the risk factor for pre-diabetes from a hemoglobin A1C of 5.7 up to 6.4 came from. Because really before that, it was things like impaired fasting glucose and glucose tolerance. So impaired fasting glucose greater than 100, or it previously was even 106. And we showed in multiple trials that if you have impaired fasting glucose, that's a pre-diabetic condition, and it increases the odds ratio of cardiovascular disease or hazard ratio by 20%. And the same for impaired glucose tolerance, which is abnormal glucose handling after an oral glucose load. And so those are kind of difficult to wrap your head around, and it takes fasting, and then what's the level? Well, impaired fasting glucose is anywhere above 100, and then you can do a 2-hour glucose tolerance test, and if it's greater than 140, then that is diagnostic. But now it's much easier to draw a hemoglobin A1C, because they're essentially in the same spectrum of pathophysiology. And this is really where pre-diabetes here is kind of taken hold. So we'll go through that here more. So what's the pre-diabetes epidemic? Well, it's 80 million adults. Well, diabetes is 25 million adults. Oh my gosh, so it's staggering. So we're talking about over a threefold increase in those that have just pre-diabetes. So 50% of U.S. adults over the age of 65 have pre-diabetes, where it's about 25% that are diabetic. So this is a staggering amount of individuals that are at elevated cardiovascular risk. Okay. So this is just another example of what the prevalence is in men and women across age, and it's pretty equal in men and women. You can see across age, and then a high prevalence in older individuals beyond age 50 and 70, and creeping up rapidly in those in their 40s and 50s as well. So not only is there pre-diabetes, which increases cardiovascular risk, but there is the metabolic syndrome. And so the metabolic syndrome is a constellation of risk factors. One of those risk factors includes levels of hyperglycemia, which would be an elevated fasting glucose greater than 100, so impaired fasting glucose. But it also includes differences in abdominal adiposity, differences in men and women, elevated triglyceride levels with suppressed good cholesterol or HDL levels, and then the presence of hypertension. And it's really these combination of risk factors that can lead to increased cardiovascular risk as well. So this is from the Framingham data. And overall, individuals with just metabolic syndrome have really a 7-fold increase in developing diabetes compared to those that do not. And so in this cohort, there's about 20% progress to diabetes from metabolic syndrome within 8 years. In the San Antonio Heart Study, there were similar features, but you can see your highest risk for progression to diabetes is if you already have impaired fasting glucose as a part of your metabolic syndrome criteria. If you did not have impaired fasting glucose, if you did not have impaired fasting glucose but you had metabolic syndrome, you still had a higher hazard ratio for the development. But really with impaired fasting glucose, that progression to diabetes is much more likely. So not only is it metabolic syndrome, but it's metabolic syndrome plus degrees of hyperglycemia that predict progression to diabetes, and it's diabetes and those intermediate hemoglobin A1Cs that predict risk. And so what are some of the 10-year incidences of cardiovascular disease and mortality in people with metabolic syndrome? Well, depending on their age, they can be pretty darn high. So up well above 10% in the majority of patients with metabolic syndrome, depending on their age and looking at their outcomes. The incidence of combined endpoints in women was lower than it was in men, and this is in a young population cohort, so that would be expected just based off of their age. But compared to having no metabolic syndrome and having the presence of metabolic syndrome in females, it's not as high as men, but it's still significantly elevated in women compared to those who do not have metabolic syndrome. So is there any evidence that we can lower the risk of the development of diabetes when you have these high-risk features, prediabetes and metabolic syndrome? And the answer is yes, we do. We have a great risk modification program, and it's called weight loss, exercise, and therapeutic lifestyle interventions. So we're fortunate at OHSU and in the Portland community that we're now on our third cohort of enrolling people into the diabetes prevention program. This is a study that was done in Boston, I think, in the early 2000s. And it looked at those with prediabetes, placing them on a placebo to help with their prediabetes, putting them on metformin, or putting them on an aggressive lifestyle management program, which is a 16-week course about how to eat healthy and how to exercise and how to maintain or obtain about an 8% weight loss. That we noticed that those that went on and were followed for about 4 years, there was a 58% reduction in the lifestyle modification arm for those that completed the classes and were able to obtain weight loss. And so this is for the development of diabetes. This was markedly better than medical therapy with metformin and vastly superior to just standard of care, which is good luck, exercise, and lose weight. So these slides and the data are available to the public on the CDC website, where you just type in diabetes prevention plan, and all this information and class stuff is available for you. Then what they did is they looked at people that went into the diabetes prevention plan, had weight loss, and then after 4 years, the study was stopped, and they said, well, we got to get all these other people into the DPP. And then they followed them all out for 10 years. And even though with lifestyle modification, you lose a bunch of weight, after time, these people will regain weight, and then they'll kind of be back up to kind of what not what their prior weight was, less than placebo, but kind of metformin and induced weight loss. But you'll see that those that, even though they regained their weight, they adopted healthy lifestyles and likely continued their physical activity, still after 10 years, despite being the same weight as metformin, they still had a significant decrease in the development of diabetes when compared to placebo. So a reduction by 34%, where metformin was only around 20%. So still 16% risk reduction benefit with therapeutic lifestyle modification over 10 years period of time for the development of diabetes. That's pretty powerful. Well, so that's for the development of diabetes, and how about for if you have prediabetes? Well, what about if you have metabolic syndrome? Well, there's an exercise training plan for individuals as well, where researchers looked at 4 different groups of people that they randomized. They said, well, we're going to just say, people, you be on diet and we'll see what happens to you. We're going to prescribe a specific low amount of moderate intensity exercise. We're going to give people a low amount of vigorous intensity exercise, and we're going to give people a high amount of vigorous intensity exercise. And they followed a certain prescription where they looked at the amount of kilocalories they were burning per week. And then they looked at the prescription for exercise time. So even in this group, they were burning between the low amount moderate and the low amount vigorous intensity exercise. They were burning the same amount of calories per week. This group, though, was moderate exercise. They exercised more amounts. These people exercised less amount but more intense. And then they followed them compared to this group. And what they found was the time that you're in exercise markedly reduces basically a Z-score for bringing down all your metabolic risk syndromes. So these were people that exercised about 180 minutes a week, 4 times a week. These were people that had only exercised 2 to 3 times a week, 120 minutes. These were vastly superior to this group, so the high intensity group, but that there was probably an added benefit if you were able to do it vigorous intensity for more prolonged bouts of exercise. So that there's a stepwise improvement in intensity, but a lot of it is the amount or the numbers of hours you're exercising per week. These 2 groups were at 180 minutes. Compared to this group that was less than 150. So that's pretty powerful in reduction of their criteria for the metabolic syndrome. Okay. So not only do we have weight loss, not only do we have exercise, but looking at a bunch of clinical trials and treating hypertension, there's a trend that ACE inhibitors and angiotensin receptor blockers carry the lowest risk for people that are treated with antihypertensives for the development of diabetes. So I personally believe, based off of this, that these are, I use them as the antihypertensive of choice in people that are obese and at risk. And I will utilize those before I will utilize any diuretic for people. I think a diuretic is merely masking the underlying problem. It may help with their hypertension, but I think this is powerful data. Yeah.
Didn't the all-hat study come out after this study and show that chlorothalidone was equal to all those other antihypertensives, even with diabetes?
Probably for, I'm not sure for diabetes. For outcomes, I believe you're right, but I don't know for diabetes. You may be right. I'm biased. These help with decreasing proteinuria, unloading the glomerulus, help decrease the perfusion pressure across the glomerulus and diabetic nephropathy changes. And as a cardiologist, we're utilizing them all the time. And I have other agents that I can add on if edema is still a problem for hypertensive people after I've started an ACE inhibitor for them. So moving on from that, so what's the risk of what's the cardiovascular risk with the development of type 2 diabetes? No transitioning from the metabolic syndrome and pre-diabetes people to diabetes risk. And so we mentioned that the presence of diabetes is a coronary artery disease risk equivalent, and it comes from this East-West study. It was kind of proven in the UK PDS, but this is the East-West study that showed that if you have no prior heart disease but the presence of diabetes here, you're at the same risk of having a first heart attack as someone who's already had a heart attack. That's pretty staggering. So If you look at then metabolic syndrome and diabetes and the additive risk then of these factors, and looking at coronary heart disease and cardiovascular disease mortalities, your reference being that you have neither metabolic syndrome, diabetes, or cardiovascular disease, there's a stepwise increase in your relative risk for heart disease death with metabolic syndrome, additive with diabetes, further added if you have known cardiovascular disease, and markedly increased in the presence of cardiovascular disease and diabetes. So what can we do to lower cardiovascular risk then? So the Steno-2 trial, I think, is a trial that gets overlooked, and it's because it was a pretty small trial. It was 160 patients. 80 went into a conventional therapy arm, and 80 went into an intensive therapy arm. And it was open kind of study as well, such that the people on intensive therapy knew that they were getting intensive therapy. But they all went through intensive therapeutic lifestyle change. They had their hemoglobin A1Cs targeted to 6.5% or less, and then tight titration of all lipid factors and blood pressure. And the primary endpoint of cardiovascular events in this small, randomized but open-label trial was rather significant, that those on intensive therapy had less myocardial infarctions than those on conventional therapy. So this is evidence that would suggest early intensive therapy will reduce risk of cardiovascular disease outcomes. This was a population of 55-year-olds. This is a younger population. This is catching it early and treating it aggressively. Their risk factors, though, were that they had the presence of nephropathy or microalbuminuria. So they had to get into the trial, it was young people with elevated risk based off of nephropathy. Intensive treatment helped with nephropathy, microvascular outcomes, but it also helped with macrovascular outcomes. So that is not the same, though, in Proactive Accord, Advance, or the VA diabetes trial. These are trials that looked at, can we reduce risk in people that are diabetics, that have had prior heart disease in the VA trial, very high risk in Advance and Accord, and an elderly population. And you can see that in all four of these trials, we did not reduce cardiovascular disease rates or death. And actually in Accord, with hypoglycemia, there was an increased risk in cardiovascular death. This is a different population of people. They are older. They have had diabetes for about 6 to 10 years, an average of 8 years across these trials. That is a different cohort than the cohort I showed you before from the Steno trial. Now let's compare that to all comers in UK-PDS and then UK-PDS follow-up. So what was UK-PDS? It was first onset recognition of treating your diabetes. Hemoglobin A1C could have been 10, could have been 7, could have been 9, but it was first onset diabetes treatment randomized to conventional treatment, which was at the time medicines and lifestyle, versus sulfonylureas and insulin versus metformin. And I'll call to your attention that in the obese population that was given metformin, we had the best reduction in cardiovascular events early on. So again, this is a population early beginning treatment of diabetes where we reduce cardiovascular events. So we may think about reduction of cardiovascular events and mortality differently with aggressive treatment depending on how old they are, what their disease underlying burden is, and when they're presenting in their pathophysiology, early versus late. You may choose your glycemic management guidelines differently, and we'll get to that. So this is the reduction in the metformin sub-study with a marked reduction in myocardial infarction and coronary deaths with the treatment of metformin over conventional, which was diet, and it was actually superior to insulin and sulfonylureas. There was so not only is glycemic control important, which we've talked about, blood pressure control is just as important in people with diabetes. You'll get a bigger bang for your buck with intensive hypertensive management based off the UK PDS trial than you will with glycemic management and tight glycemic control. So blood pressure reduction, and here's how they define tight blood pressure reduction, less than 150/85. We pushed that to kind of 130/80, and now the newest American diabetes guidelines are back to 140/90 unless there's been prior myocardial infarction, you have nephropathy. So there's a little leeway here, but definitely less than 140/90 will give you additional benefit. And you can titrate people as needed based on their risk to 130s/80s. So not only is systolic blood pressure important, but treatment of diastolic blood pressure is important in patients with diabetes. So it was really this hypertension optimal treatment trial that looked at the effects of treatment and targeting diastolic blood pressure control. In those with diabetes, there was a reduction in events. So what about cholesterol? So statin provides benefit in patients with diabetes. So this is the heart protection study and looking at LDL-C levels, whether they were low or they were high in patients with and without diabetes. And all people in the trial had a cardiovascular benefit with a statin. In the presence of diabetes, with high, in the presence of diabetes, even with low entrance LDLs. So this I like because this kind of puts it all together. This is a population study of the Portland, Vancouver area done by Kaiser Health, and they looked at all the members of Kaiser kind of within our region, which was 26,000. They had newly diagnosed type 2 diabetes, and they followed them until they were hospitalized for heart disease or stroke, because that's what kills people. Okay. And they looked at, well, what are their, in controlling risk factors of hyperglycemia by hemoglobin A1C, cholesterol, and blood pressure, what were the outcomes? And you had a 2 to 3 or 2.5 to 3-fold reduction in events if you were able to keep all three here under control. And these were your biggest bang for your buck again, and controlling these is systolic blood pressure and LDL control. These weren't different from each other. But you get a marked reduction if you can get these two, and ideally all three under control. So that's blood pressure, less than 130/80 at the time for this, an LDL less than 100, and a hemoglobin A1C less than 7. So all three together are important for reduction of cardiovascular events. Okay. So hopefully we've put that together, that these are the three main things we're kind of overall assessing, as well as functional capacity in people with diabetes. So here, please feel free to utilize these in your clinic as patient handouts. This is straight from the American Heart Association. What are life's simple 7? Don't smoke, eat healthy, be active, take control of your blood pressure, take control of your cholesterol, and be aware of what your blood sugar is. So how often should glucose be tested? Well, that depends really kind of upon your risk. If you're on insulin therapy, it should be 3 times a day. There can be targeted testing I'm not an endocrinologist or a diabetologist, but when people are invested in their health, which is what testing is, we believe that that helps overall with their management. And it gives us insight, and the patient's insight about what they're eating and what other therapies may be of option for them. So the overall reaching goals are that before a meal, you want your blood sugar to be less than 130. 70, 130, you don't want to be hypoglycemic and you don't want to be hyperglycemic. And then after meals, you want to be able to keep that less than 180. Ideally, if you can do that through the day, then you'll have a goal of a hemoglobin A1C less than 7. But again, our goals are different based off of how old you are, how long you've had diabetes, and if you've already had cardiovascular problems or problems with hypoglycemia. So that hemoglobin A1C of 7 that we tried to push below in high-risk individuals, it backfired on us because they were higher-risk individuals. In the younger population, in the early onset of diabetes, it didn't backfire on us. We reduced cardiovascular events. We reduced microvascular events. So knowing the age of your patient and their underlying risk will help you kind of pick the glycemic control for them. But then blood pressure and cholesterol management should be aggressive for all of them. So 140s is really what we're at now, with titration to 130s for many people. For anyone that has diabetes and hypertension, there's a class 1 indication to be on an ACE or an ARB. They work on the back side of the kidney. This is how you can remember it, and it just unloads the perfusion pressure of the kidney. So you reduce that. You will accept a little bit of a higher creatinine when starting it because the pressure difference across that glomerulus is a little bit reduced because you're vasodilating the backside. So that's okay. It reduces microvascular events. It reduces cardiovascular events. In the absence of hypertension, but you have protein in your urine, then there's still an indication for a low-dose ACE or ARB treatment. These are the desirable numbers for cholesterol. This is prior to our newest guidelines, but I still think it makes sense to engage people in what they are. We know that there's a relationship between high LDL levels and high events and lower LDL levels and lower events. We just haven't proven by trials that if I titrate your medicine and get you to a low event, that the titration is helpful. That's why there was a change in the guidelines, because there's no evidence to say, take this, then take this, and then take this, and then take this, and get to here, and you'll do better. It was the high dose in high-risk people that lowered it either by 30% or 50% that got them to low levels. We extrapolated from that, which is reasonable, but now we've kind of shifted our thought. I will still look at, here's how we, or I, evaluate people and their risk in the clinic, is that if they have established diabetes, dependent on where they are in their pathophysiology, we know that they're at least moderate and maybe high risk, and thus will advise moderate to high risk statins for them. For people that are younger and who are physically active, I will likely start with a moderate intensity statin. Many of them have been on low intensity statins before, and then we can have a discussion on follow-up depending on what your LDL level gets to. If you're at a level that we thought correlates with lower events, then we can continue on a moderate intensity statin dose. But if you're not there, then I think there's reason to say that a lower LDL level still may be beneficial for you based off of prior guidelines. So that's how I work through it. So what else can be done besides glycemic control, blood pressure control, and cholesterol control that we do in the office? Well, it's everything that goes on in the 23 hours and 30 minutes when they're outside of our office. And so if we could give a pill to people that did all this, everybody would take this pill. It reduces your risk of death. It reduces your weight. It reduces coronary artery disease. It reduces your blood sugar. It can help get you off blood pressure medications. It can help you feel better. It can take away anxiety. It'll make you strong and healthy and help control your weight. And we all know what it is. It's physical activity. It's exercise. But we spend time modulating blood pressure and glycemia and cholesterol, and the last thing we think about is functional capacity. Okay. Well, I've told you functional capacity and the amount and your exercise prescription is important in reducing your metabolic syndrome criteria. It's important in reducing your risk for diabetes. What about if you already have diabetes and you're either young or you're more than young? Well, yeah. So if you have low mets, we've shown before that your risk of death is significantly elevated. Now, if you titrate that, remembering what we've talked about from our morning study about metabolic equivalence and overall cardiovascular risk, you have anywhere from a 2.5-fold, even in not so young, to a 5-fold reduction in your adjusted risk of dying based off your functional capacity in the presence of already having a high-risk feature for coronary artery disease and death. This is how important physical activity is in diabetes. It reduces your risk of dying. So, if I was unfortunate enough to have diabetes, I'd want to be here. Okay. What do we know about weight in diabetes? Because a lot of people say, you know, I exercise and I lose a little weight and then it comes back. Well, we know in people that exercise, at least in the diabetes prevention plan, that regain their weight, they still had risk reduction. So in diabetes, in patients with diabetes that are normal weight, overweight, and obese by a BMI criteria here, there's still a reduction in risk at high weights. So even in the absence of weight loss and being overweight, you can titrate exercise, and your highest amounts of exercise, 8 and above, lowers your risk of cardiovascular death even in the presence of being obese by a BMI of 30. That's powerful for people to know. They shouldn't be, they shouldn't stop exercising because their BMI is not changing. There's power to exercise beyond the weight, and that is what this suggests. Okay, so this is just kind of putting it all together. What does that do? It reduces your blood sugar levels. So if you think about where does glucose need to be stored? Glucose has to get into your skeletal muscles. That's what utilizes it. Fat cells utilize it too. If you exercise, you increase your blood flow to your muscle. Where does that glucose go then? What does it need to do? It goes into the muscle. So blood flow to the muscle helps get rid of glucose. It delivers the insulin there. It delivers the glucose there. The muscles utilize it. It's a way to reduce hyperglycemia. And that's what it does. Helps control weight. With all that, there's blood pressure reduction, and you feel better and you live longer. So how much do you need to do? The physical activity guidelines suggest that you do at least 150 minutes of moderate intensity exercise per week. So that's 30 minutes a day, 5 times a week. In the metabolic disease paper that I showed you before, they got up to 180 minutes a week. Either moderate, and then there was a benefit in those that were higher vigorous activity exercise. So, but the guidelines remain at 150. In addition to aerobic exercise, strength training, just moving the muscles with low weights is important as well, and there's evidence that that can have added benefent.
Sorry, I always questions are always arguing about all my people, all day long.
Mm-hmm.
And I always, I don't guess I know you're doing counsel with them as support and move your body.
Mm-hmm.
It's not accurate. Do you have another kind of argument for them to get out there first?
Yeah, so when you look at the physical activity indexes, it's what you've done on your leisure time physical activity. So typically bouts of work in the house are not prolonged, sustained, with heart rate increasing to 65 to 85% of your maximal adult predicted heart rate to achieve caloric burning for fat weight loss. It just doesn't happen. Now, it's important to be active around the house, but above and beyond that, what you can say is, okay, I know you're very active, but maybe what you need to start with beyond kind of the active day is not 30 minutes, because 30 minutes is hard to achieve. It's very hard to achieve. So you start with 10 minutes. And 10 minutes is easy to do. It's you walk 5 minutes away from your house, and you turn around and you come back. And then there are guidelines that you can use for people. Well, everybody can walk, but they usually just kind of putz around. So we can get into this, and I think it's in here as well. So walk with someone, and your conversation should be 3 to 4 words. If you're having a conversation like we are here, you're not pushing yourself hard enough. And that's kind of where you can start from, and that's kind of how I do it with people. The other suggestions that I have for people in clinic that are very busy during their day, and they're kind of driving long hours to work, and they find themselves in the car and stuff like that is, well, okay, well, where do you park before you go to work? Do you drive do you circle around for 5 minutes to find the nearest parking spot, or do you want to park 10 minutes away and walk in? There's a great way just to increase your physical activity in the morning before work and on the way home from work back to your car, as long as it's a safe environment for people. Now we have to kind of incorporate that. But there are little things that you can do during your day: parking farther away at the store, parking farther away at work, taking the stairs instead of the elevators. All those things are additive and beneficial outside of what's done on day-to-day activities. Okay. So these are all the things that are helpful, which is essentially being active. And you want to kind of tailor these to what are people's needs as far as their physical capacity, what their weight is, what their joints are like, and things like that. So water aerobics classes, ability to get to pools or gyms that have recumbent bikes or machines that offload their joints so they can get a little bit of a weight loss before they start with a walking program. Because if someone isn't able to walk and you tell them all you need to do is walk 10 minutes a day and they can't do that, then they're not going to do it. So we have to be kind of thoughtful about what our recommendations are and what resources patients have in their community, what resources they have at home and around their home and outside their home. So those can be challenging. A lot of times they are very challenging. So this is the kind of the moderate exercise. So the intensity is being able to talk a couple words at a time, but not being able to like walk and sing. You know, like if you're doing that, you're not pushing yourself. You're not going to get the benefit from it. So I already kind of skipped ahead and I kind of talked about this. The exercise helps get little insulin guy, blue, and glucose guy to your cell. That's what we're hoping to achieve, and then break that pathophysiology. And to get the full benefit of exercise, don't let 2 more days pass between exercise sessions. So repeated bouts of exercise help with endothelial nitric oxide, that helps with vasoreactivity, that helps with vasodilation, and all those things. You can take this is kind of cool, you can take a trained athlete, cyclist, marathon runner, and you can put them in a waterbed for 3 days, and they will become insulin resistant by doing an insulin tolerance test, by doing an insulin clamp. Inactivity is the beginning. Weight loss helps. Weight management helps. Weight management is challenging. It should be discussed. There's no way around the fact that although weight management is hard, it's a balance of the caloric intake you put in, your own metabolic rate, and your caloric output. That is how people gain weight, is when that relationship is shifted. That caloric intake exceeds caloric output, plus their own basic metabolic rate. How is it to gain weight? 100 calories a day, 10 pounds in a year. That is, if you do everything the same all day, every day for the year, and match your caloric intake, and you eat an Oreo cookie every day. One Oreo cookie, 150 calories, you gain 10 to 15 pounds. Okay. I found this very helpful when talking about how to put together healthy meals and plans for people. Basically, this is from, I think this is from the CDC, and there's something called My Plate as well. Take a plate, and you cut it in half, and on half of it, it's fruits and vegetables. And then the other half, you cut in half, and one's your starch, and one's your protein. So that's an easy way to divvy up what your plate looks like, and it's a good starting point. So eat more vegetables and less of everything else. There's fiber in all that stuff. Keeps it in the gut, helps clear it out better, slower glucose and carbohydrate absorption, things like that that are beneficial. Some information about carbohydrates and things like that for your patients if they have diabetes. Where do calories come from that are easy to get? They come from juices and sodas and beers and other high caloric dense liquids. Don't eat at McDonald's. Just don't eat fast food. If you can tell your patients one thing, stop eating fast food. Cook your meals. You know what you're getting. This does not count as taking your dog for a walk. So when they say, I walk my dog, ask them what they mean by it. And if it's this, that's not beneficial. There we go. I'll stop.
Scott, can I ask you a question?
Yeah.
Fantastic. So, over the past several years, you've noticed that what the guidelines for exercise should be keep shifting. What's the thinking behind it? And several years ago, for example, the AHA came up with this statement, and then I think it starts to confuse all of us. So, where exactly is the science standing, and why are they keep changing the guidelines, especially downwards, right?
Yeah. So the big plan was to do this trial with diabetics, and it's called the Look Ahead trial. And it was put people on all these exercise recommendations and look at their cardiovascular outcomes, saying that exercise is going to be the modulator that's going to reduce cardiovascular outcomes. And it was a negative trial. It didn't work. And so that hasn't, I don't know if that's been the overall driver or not, because that was just within the last year or so. But I don't know really what the shift is. A lot of it, I think we get good outcomes in younger individuals early in the pathophysiology, and later in the pathophysiology and or later in life, if we're picking a wide population, we're going to narrow or negate those benefits by a higher risk cohort. So, yeah.
I'm sorry to ask. Because you alluded to just having your patient walk 10 minutes more in the morning, 10 minutes at night. Is it the same benefit to do 10 minutes of vigorous exercise 3 times a day, or 30 minutes all at once? What does the study show? I haven't done the studies.
From a reduction of weight and a reduction of from a reduction of weight, you're going to probably get more caloric output in your longer exercise regimen. You're just going to burn more calories from that. Your cardiovascular health will probably improve because of that. But in a way to engage a person in getting active, at least the 10 to 15 minute period will have some benefits to it. So additive exercise in that is beneficial. Some is good, more is better.